and I will be discussing the case study of Chris. Chris is an African American married male who reports that 3 years ago he began noticing intense sexual impulses for abnormal sexual behavior, such as pornography, sexting, online chat rooms, public sex, and recently an extramarital affair. He reports that these avenues provide social interactions as well as an increased mood. Chris reports confusion, anxiety, shame, and depression surrounding his actions. He also reports shame and guilt surrounding his religious beliefs and his deceit towards his wife and children, which do not seem to align with his values and morals. He reports that his increased time online has caused increased tension and disconnection with his romantic relationship. However, he does not feel comfortable discussing these issues with his wife. The first treatment that I feel would be beneficial for Chris is cognitive behavioral therapy. CBT is a type of psychotherapy that helps individuals manage problems by changing the way they think and behave, focusing on the relationship between thoughts, feelings, and behaviors to improve emotional regulation and develop coping skills. It's a versatile treatment approach suitable for a wide range of individuals and conditions, including those with depression, anxiety, phobias, and PTSD, as well as those struggling with substance abuse, eating disorders, and personality disorders. CBT is aimed at addressing compulsive sexual behaviors, generally consists of 5 to 20 sessions, each ranging from 30 to 60 minutes in duration. The total number of sessions and their length may differ according to the specific needs of the individual and the intensity of the behavior, as well as the progress made by the patient. However, according to Giordano, the recovery and treatment process for sexual addictions can take approximately 3 to 5 years. While some individuals may experience considerable improvement after just 4 to 6 sessions, others might need more than 20 sessions to achieve similar results. While CBT is generally safe, some potential risks include initial discomfort, potential triggering of past traumas, and the possibility of worsening symptoms in rare cases. These risks are typically manageable with a skilled counselor and can be minimized by open communication and proactive management of any difficulties. The counselor serves as both a facilitator and an educator, guiding the client in recognizing and altering detrimental thoughts and behaviors. Conversely, the client plays an active role in the process by sharing their experiences, acquiring new skills, and implementing them in practical scenarios to attain their goals. Lastly, to ensure that treatment is effective and respectful of individual differences, culturally responsive CBT requires tailoring interventions to match the client's unique background and experiences. It also involves acknowledging and addressing potential biases and power dynamics in the therapeutic relationship. In CBT, techniques such as deep breathing, thought-stopping exercises, and structured problem solving help individuals regulate their emotions without turning to compulsive sexual behaviors. In the context of compulsive sexual behaviors in CBT, thought-stopping involves disrupting and replacing negative or intrusive thoughts with more positive and neutral ones, helping to manage impulses and develop healthier coping mechanisms. Thought-stopping involves identifying triggers, challenging these negative thoughts, and recognizing patterns. Techniques in thought stopping include awareness, interruption, and cognitive replacement. Another technique used in CBT that can be useful in Chris's situation is structured problem solving. One way of utilizing structured problem solving with Chris is through cognitive restructuring. Cognitive restructuring can help individuals with compulsive sexual behaviors by identifying and challenging negative, unhelpful thoughts and feelings that fuel these behaviors, ultimately leading to a healthier coping mechanisms and reduced urges. As a counselor, I can aid the discussion of cognitive restructuring by utilizing Socratic questioning to explore Chris's thoughts and emotions in more detail. Lastly, deep breathing techniques may be very beneficial for Chris. Deep breathing, which is a mindfulness technique, can help individuals with compulsive sexual behaviors by reducing stress, anxiety, and impulsivity, and promoting self-awareness and creating healthier coping mechanisms. In CBT, there are several deep breathing techniques, including box breathing, 4-7-8 breathing, and alternate nostril breathing. Another theory that may be beneficial for Chris is psychodynamic theory. Psychodynamic theory is especially beneficial for individuals who wish to investigate the unconscious origins of their behaviors and emotions. This approach is particularly relevant for those facing intricate challenges or desiring a more profound comprehension of their internal experiences. It tends to be effective for individuals dealing with concurrent substance abuse disorders, existing psychological conditions, or those open to self-examination and gaining insight. Psychodynamic therapy can vary in duration with both short-term and long-term approaches. Short-term therapy typically involves 25 to 40 sessions, while long-term therapy may extend for a year or more and is dependent on the goals of the treatment and the individual's specific needs. Psychodynamic therapy, although it may offer advantages, also presents certain risks such as emotional distress, the chance of re-traumatization, and the possibility of misinterpretations by the therapist. These risks can emerge from delving into challenging emotions, revisiting traumatic events, and depending on the therapist's interpretations that might not be precise. Furthermore, the extended duration of this therapeutic approach can result in dependency and higher financial expenses. In the psychodynamic counseling framework, the counselor serves as a facilitator, assisting the client in delving into their unconscious thoughts and emotions and historical experiences to gain insight into their present behaviors and interpersonal relationships. The client participates actively in self-examination, free association, and the investigation of their emotional responses and behavioral patterns, aiming to achieve greater self-awareness and facilitate personal transformation. Differing from CBT, psychodynamic theory focuses on unconscious processes and past experiences and can be used in treating compulsive sexual behaviors to explore underlying conflicts. However, both psychodynamic theory and CBT aim to develop self-regulation skills. Psychodynamic theory states that compulsive sexual behaviors may stem from unresolved conflicts often rooted in early childhood experiences that manifest as compulsive behaviors. Therefore, if we were exploring Chris's case from this theory, it would be imperative to explore past childhood experiences as well as unresolved conflicts from previous developmental stages. It would also be imperative to explore Chris's unconscious thoughts to bring them to light, allowing for the discovery of motivations behind Chris's behavior. Somewhat like cognitive distortions, psychodynamic theory focuses on defense mechanisms, which are ways an individual makes sense of and justifies a situation. For example, Chris may be experiencing displacement. He has many sexual urges and fantasies in which he feels his life would be disapproving of. Therefore, he fulfills these urges through strangers on the internet and through pornography. Next, regarding sexual addiction, African American males are 2.5 times more likely to report clinically significant distress from difficulty managing sexual urges than Caucasians. According to Motley and Banks, it has been proven that sexual addictions occur in men who relate the most to the insecure attachment style. Also, men with addictions were likely to have increased avoidance behaviors as well as increased anxiety responses in their romantic relationships. Lastly, there are many cultural factors that can influence addiction in African American community. First, African Americans are disproportionately affected by poverty, which can lead to increased stress, limited access to resources, and higher rates of substance use as a coping mechanism. Brooks and McHenry identified that over 25% of African Americans did not feel welcomed at 12-step meetings and felt that they were not enough of African American role models in recovery. Brooks and McHenry identified several key factors that affect the decision for African American clients to seek treatment. These factors encompass spirituality, the influence of the church, the position of women in the family, and the collectivist perspective. According to the American Psychological Association, collectivism is a social or cultural custom, belief system, or independent perspective that prioritizes the cohesion of the group or community over the uniqueness of everyone. I believe this would be very interesting to explore with the case of Chris. Chris mentions that he is feeling increased anxiety and depressive symptoms due to his sexual urges as well as his extramarital affair. I would be curious to explore whether he is going against the collectivism approach is causing him these feelings. Next, when referring a client to a 12-step meeting, a counselor should prepare the individual for the likely chance that there will be a small amount of minority individuals within the group. Therefore, by understanding my client's spiritual and religious preferences, I could better assist him at finding support groups that fit his needs. As a counselor, it is imperative that I explore my client's view of family and explore whether involving the family in the treatment process would also be beneficial. Chris reports For the last 3 years, he has been experiencing unwanted, intense sexual impulses. This led Chris to engaging in pornography and internet chat rooms where he could sex. He reports that these urges have continued to strengthen, and he recently had an extramarital affair with a stranger he met on the internet. These behaviors have caused Chris several unpleasant symptoms, including confusion, shame, and depression, disconnection from his wife, and fear of harming his children. The first step would then be to assess Chris. One assessment that would be beneficial for Chris is the Sexual Compulsivity Scale. According to Giordano, the SCS consists of 10 items that are based on the literature surrounding sex addiction. The developers of the scale define sex compulsivity as a persistent, repetitive, intrusive, and unwelcome impulse to engage behaviors frequently executed in a ritualistic or habitual manner. The SCS includes statements like, "My sexual desires have interfered with my everyday life." Participants indicate their level of agreement with each statement using a 4-point Likert type scale, which ranges from not at all like me to very much like me. The overall SCS score is calculated by adding the scores from all 10 items. One other assessment I would use with Chris is the Sexual Addiction Screening Test Revised, the SAST-R. As stated by Giordano, the SAST-R incorporates culturally pertinent inquiries and subscales that address variations in gender and sexual orientation. The assessment consists of 20 items, and a score of 6 or higher suggests the presence of sexual addiction. Since both assessment tools are self-administered, it would be imperative to follow up this testing with discussion with Chris in order to gain more insight and understanding into the way he answered. Next, I would perform a psychological evaluation or mental health exam with Chris. Here I would explore several things with Chris, including physical and mental health, as well as overall emotional well-being. I would also explore sexual thoughts, behaviors, and urges, use of substances or lack thereof, family, relationships, and social life, as well as concerns caused by sexual behaviors. It is important to note that these assessments are all self-administered, which has the potential to be problematic due to potential bias, misinterpretation, and lack of standardization. Therefore, I will use these assessments as a guide for treatment. In the case of Chris, several diagnoses may need to be explored. Based on the nature of this course, my first step in exploring Chris's potential diagnosis was the DSM-5-TR, specifically the substance-related and addictive disorders. However, based on the information Chris gave me in our initial session, I do not believe that Chris has an issue with substances. He does not mention using any substances, including alcohol or illegal/prescription drugs. Therefore, it would be imperative that I gather more information from Chris throughout our sessions through discussions and assessments such as the biopsychosocial, to see if substances play a role in his life. Secondly, Chris indicates that he discovered a means of escape through pornography and online chat rooms. He has shared that he has been secretly dedicating increased amount of times to the computer, which has resulted in heightened conflict and emotional detachment from his partner. He notes that pornography and chat rooms appeared to offer him a beneficial outlet, facilitating not only social interactions but also connections with individuals who enhance his mood. While the DSM-5-TR does not recognize pornography or the internet as specific addictions, it would be important to explore the weight of these activities on Chris's day-to-day functioning and overall life satisfaction. It is also important to understand whether these are addictions in and of themselves or if they are symptoms of a larger issue. To evaluate issues related to pornography consumption, I would utilize the Problematic Pornography Consumption Scale. This extensive scale is specifically crafted to measure problematic pornography use through 18 items, each assessed on a 7-point Likert scale. It covers multiple aspects such as salience, mood alteration, conflict, etc. To evaluate potential issues related to internet usage, I would employ the Internet Addiction Test, designed to gauge both the existence and intensity of internet dependency. The IAT focuses on self-reported compulsive internet use and examines symptoms associated with internet addiction across various contexts. One diagnosis I would be interested in exploring is obsessive-compulsive disorder, or OCD. According to APA, obsessions are defined by recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted and are marked by anxiety and distress. Also, the individual has attempted to ignore or suppress these thoughts. Chris meets these criteria as he has been experiencing several sexual urges, fantasies, and desires and has failed to suppress these urges. According to APA, compulsions are defined by repetitive behaviors that the individual feels driven to perform in response to an obsession and are mental acts that are meant to reduce anxiety or distress. Chris has begun engaging in chat rooms, pornography, sexting, and public sex with people other than his wife. These activities for Chris have been time-consuming and have caused him to argue more with his wife. These activities have been causing Chris significant distress in several areas. As stated, he's arguing with his wife more, and he also reports conflicting beliefs with his religion, as well as shame regarding his children. Moreover, these symptoms are not attributable to the effects of a substance, as Chris does not mention substance abuse. However, due to the nature of Chris's symptoms and their focus on sexual behaviors, I felt it was important to go a different route. When looking in the DSM-5 Handbook of Differential Diagnosis, a differential diagnosis listed under OCD was Generalized Anxiety Disorder, or GAD. According to APA, an individual meets criteria for GAD if they have experienced increased anxiety for at least 6 months surrounding several events or activities, they have difficulty controlling this anxiety, and experience at least 3 of the symptoms associated with anxiety, including sleep disturbance, muscle tension, fatigue, etc. This anxiety must cause clinical impairment in functioning in the client. When basing a diagnosis of GAD off this first initial session with Chris, I do not believe I can rule this diagnosis in or out as of yet. Chris does seem to be experiencing this anxiety in several areas of his life, including his family dynamics and his religion. Chris reports that he does not think his partner will understand his sexual urges, leading him to explore these urges through pornography, chat rooms, and an extramarital affair. He also reports that these urges are in conflict with his religious beliefs and values. He reports that he has been experiencing these symptoms for 3 years. However, during the initial session, Chris does not mention feeling restless, irritable, having trouble concentrating, experiencing muscle tension, or having sleep disturbances. Therefore, more information would need to be gained to rule in or out a diagnosis of GAD. One assessment that would be beneficial to guide this diagnosis is the Generalized Anxiety Disorder 7, the GAD-7, which is a brief self-administered questionnaire used to screen and assess for the severity of GAD. There are 7 questions, and each question asks the individual to rate how often they have experienced certain symptoms like feeling nervous, anxious, or on edge over the past 2 weeks. Respondents are scored on a 4-point scale. It is also important to explore whether his symptoms of anxiety are due to his increased use of compulsive sexual behaviors or vice versa. When looking at the DSM-5 Handbook of Differential Diagnosis, a differential diagnosis listed under GAD was adjustment disorder. As outlined by the APA, to diagnose an adjustment disorder, there must be an identifiable stressor, meaning that the symptoms arise directly from a specific stressful event or situation. Additionally, the emotional or behavioral symptoms should manifest within 3 months of the onset of the stressor. These symptoms must lead to significant distress or functional impairment in social, occupational, or other critical areas of life, indicating that the level of stress or impairment exceeds what would typically be anticipated for or based on the severity of the stressor. Furthermore, once the stressor or its effects have subsided, the symptoms should not continue for more than an additional 6 months. It is also important to note that these symptoms should not be attributed to another mental disorder or to the normal process of grieving. Chris reports that he recently had an extramarital affair, leading him to feel anxious and worried that his partner will find out. Therefore, Chris did experience a new identifiable stressor, and he is experiencing extreme impairment due to this. However, Chris did not mention when exactly he had the affair, so we would need to explore these details more to make sure it was in the last 3 months. Lastly, before concluding adjustment disorder, we would need to first rule out other diagnoses such as anxiety or mood disorders, which we do not have enough information to do at this time. Another diagnosis I felt important to explore was major depressive disorder, or MDD. According to APA, MDD is identified when a person exhibits 5 or more of the following symptoms over a 2-week time frame, indicating a shift for their prior level of functioning. Those are persistent depressed mood, diminished interest or pleasure in activities, significant weight change, sleep disturbances, psychomotor agitation, fatigue, feelings of worthlessness or excessive guilt, reduced ability to concentrate, and thoughts of suicide. Furthermore, these symptoms must lead to considerable distress or impairment in social, occupational, or other critical areas of functioning and should not be linked to substance use or any other medical condition. Chris reports confusion, shame, and depression about his urges and behaviors and doesn't feel like he can tell his partner about his struggles. He also feels conflict with his religious beliefs due to these urges. He reports that internet chat rooms provide him with the social interactions that improve his mood. It would be imperative to explore this statement and the potential feelings associated with it, such as loneliness and isolation. Based off my initial session with Chris, I do not believe that I have enough information to rule this diagnosis in or out yet. One assessment I would use to measure this is the Beck's Depression Inventory, or the BDI. The BDI is a self-administered questionnaire consisting of 21 items aimed at evaluating the severity of depression. It is structured to gauge both the presence and intensity of depression symptoms as perceived by the individuals themselves. The most recent iteration, known as the BDI-2, is commonly used for both adults and adolescents, yielding a total score that reflects the severity of depression conditions. Having Chris take this assessment and exploring these results together would help out us rule this diagnosis in or out. Due to the sexual nature of Chris's symptoms, I explored the DSM-5-TR chapter over sexual dysfunctions. Based off the information Chris has given during our initial session, Chris presents a diagnosis of F52.8 other specialized sexual dysfunction with symptoms suggestive of compulsive sexual behaviors, including recurrent and intense sexual urges, difficulty in controlling sexual behaviors, and significant distress and impairment in important areas of life due to these sexual thoughts and behaviors. Chris reports that his urges have intensified over time. He indicates that this escalation resulted in a recent extramarital affair with an individual he encountered online, which has caused him to feel anxious and concerned about the possibility of his partner discovering the situation. Also, Chris expresses feelings of confusion, shame, and depression regarding his urges and actions, and he feels unable to share his struggles with his partner. Additionally, Chris indicates that he experiences conflict between his religious beliefs and these sexual behaviors. As noted by Gola et al. In 2020, individuals experiencing compulsive sexual behaviors struggle with chronic inability to manage overwhelming and recurrent sexual urges or impulses, which results in repetitive sexual actions. These urges and behaviors are notable for their intensity and frequency, leading to considerable distress or functional impairment. The recurring nature of these sexual impulses and actions significantly disrupts personal, family, social, educational, or occupational functioning. I have chosen this diagnosis for Chris because his symptoms do not meet the full criteria for any of the other disorders in sexual dysfunction diagnostic class. Since Chris does not mention any use of substances, substance/medication-induced sexual dysfunction can be ruled out. Chris does not mention premature ejaculation, and his symptoms appear to be the opposite of the symptoms indicative of male hypoactive sexual desire disorder. Chris does not give us enough information during the initial session to rule in or out premature ejaculation and/or delayed ejaculation. In the study of Chris, there are many factors that go into choosing the appropriate level of care. However, it is imperative that I make the appropriate choice because it ensures the client receives the necessary support without unnecessary restrictions or overtreatment. With that being said, I believe the appropriate level of care for Chris at this time would be outpatient therapy. According to Brooks and McHenry, in outpatient therapy, clients attend sessions while still residing in their own homes. Clients will also be given a therapy schedule, including group therapy weekly and individual therapy weekly. Lastly, 12-step groups are often incorporated and made mandatory during treatment. Individual therapy can be highly beneficial for individuals with compulsive sexual behaviors, offering tools to identify triggers, developing coping mechanisms, and addressing underlying issues, ultimately leading to a healthier, more balanced life. Group therapy offers individuals struggling with compulsive sexual behaviors a supportive environment to connect, share experiences, and develop coping strategies, fostering self-awareness and healthier behaviors while reducing feelings of isolation and shame. Different group therapy options for compulsive sexual behaviors include cognitive behavioral therapy, acceptance and commitment therapy, and psychodynamic therapy. Lastly, 12-step groups offered for individuals with compulsive sexual behaviors include Sex Addicts Anonymous, Sexaholics Anonymous, and Sex and Love Addicts Anonymous. It is important to note that both inpatient that intensive outpatient therapy and partial hospitalization therapy were both explored for the case of Chris. For individuals with co-occurring substances and mental health disorders, IOP is often a better choice than traditional outpatient treatment as it provides a higher level of structure, support, and care. Also, while there isn't a definitive consensus on the need for PHP for compulsive sexual behaviors, it can be a valuable option for individuals with severe symptoms, co-occurring mental health conditions, or substance abuse. In the case of Chris, he does not mention any issues with substances. However, this is something we would need to explore over our sessions. Secondly, Chris mentions confusion, shame, and depression regarding his actions and conflict with his religious beliefs. I believe that these feelings and concerns should be explored and discussed sufficiently within outpatient treatment through individual, group, and 12-step sessions. However, if more issues arise during session, a reevaluation would be imperative to potentially increase Chris's level of care. Lastly, I believe it would be imperative to refer Chris to a psychiatrist to evaluate for medication management regarding his stated symptoms. For example, certain medications may be used for managing sexual urges, including antidepressants, naltrexone, mood stabilizers, or anti-androgens. According to the American Psychiatric Association, the severity of conditions is categorized from mild to severe depending on the number of criteria met. Specifically, having 2 to 3 symptoms is classified as mild, 4 to 5 as moderate, and 6 or more symptoms as severe. Additionally, there are course specifiers such as in early remission, in sustained remission, or on maintenance therapy, or in a controlled environment. An individual severity rating can fluctuate over time as the frequency of symptoms increases or decreases. However, the DSM-5-TR does not provide a severity rating for other specified sexual dysfunction, as this category encompasses sexual dysfunctions that do not completely fulfill the criteria for other more defined disorders. Instead, healthcare professionals evaluate the level of distress and the functional consequences associated with the symptoms, which subsequently inform the treatment approach. Chris mentioned several distressing symptoms due to his behaviors, including depression, shame, guilt, confusion, and conflict with his religious beliefs. Since Chris is coming to individual therapy for assistance with this issue, Chris would be considered in early remission. Therefore, I would consider Chris' diagnosis of F52.8 other specified sexual dysfunction with symptoms suggestive of compulsive sexual behavior with moderate distress and in early remission. While working with my client Chris, I will be implementing the use of Gorski's SENEPS model of relapse prevention. The SENEPS model created by Terry Gorski is an extensive framework for the assessment and management of substance use disorders, co-occurring mental health issues, personality disorders, and situational challenges. It prioritizes personal recovery and integrates multiple clinical approaches. This model is intended to be flexible, accommodating various clinical methodologies and program limitations while emphasizing the use of clear language. This flexibility is essential for ensuring cultural sensitivity, however, it is not inherently included from the outset. For example, the model can be adapted to incorporate family and community support or to address specific cultural beliefs and values related to addiction and recovery. Chris is an African American male who may face challenges in recovery due to historical and/or ongoing racism, discrimination, or social inequities. Therefore, adapting the model to explore and address Chris's cultural values and beliefs is imperative. There are several reasons I feel that this model would be effective when working with Chris. First, the SENEPS model focuses on a wide array of issues, including situational life challenges and co-occurring mental health issues, not just on substance abuse. Chris reports no issues with substances. However, Chris has reported that his abnormal sexual impulses have begun increasing over the last 3 years, and he has begun spending more and more time on the computer and in secret, engaging in online chat rooms and pornography, as well as engaging in an extramarital affair, indicating the diagnosis of F52 other specified sexual dysfunction with symptoms suggestive of compulsive sexual behavior, including recurrent and intense sexual urges, difficulty in controlling sexual behaviors, and significant distress and impairment in important areas of life. While not explicitly designed for sexual addictions, the SENEPS model focuses on addressing underlying issues and promoting recovery by incorporating principles like awareness, support, and maintenance, which can be applied to help individuals gain insight into their behaviors, develop coping mechanisms, and maintain recovery. Secondly, the CENEPS model consists of several key components that will help aid Chris in relapse prevention. The CENEPS model is comprised of several essential elements. 1. Performing a comprehensive evaluation of a client's history of addiction and relapse. 2. Recognizing the specific relapse warning signs unique to the client. 3. Formulating coping strategies to address each identified warning sign. 4. Designing a structured recovery program grounded in a developmental framework. And 5. Establishing an early intervention strategy for potential relapse. By exploring Chris's life and history with these urges, both Chris and I can identify thoughts, feelings, and behaviors that may precipitate a relapse. These thoughts, feelings, and behaviors are also called warning signs. For example, Chris reports that pornography and online chat rooms provide a helpful outlet for him by providing social interactions with people who help improve his mood. Therefore, a warning sign that may be identifiable for Chris is when he is feeling lonely or isolated. The associated thoughts and unmanageable emotions Chris reports are confusion, shame, depression, and increased anxiety about his urges and behaviors, and he does not feel like he can tell his partner about these issues. The associated self-defeating or harmful behaviors Chris presents, including isolation from the family, keeping his urges a secret for the past 3 years, disengagement from family, and engagement in these sexual urges online. The next step with Chris would be to work in collaboration to identify coping skills and strategies to manage each warning sign. Counselors may employ psychoeducation, role-playing, modeling, and assignments outside of session to assist clients in mastering these management techniques. For example, Chris may develop a plan to manage the warning signs of feeling lonely by disclosing to a trusted individual his experiences of loneliness, thereby combating isolation and withdrawal. By role-playing with Chris in session, I could aid him in feeling comfortable having this conversation with an important person in his life. Also, Chris states that his behaviors conflict with his religious beliefs. Therefore, it may be beneficial for Chris to engage in activities that increase his sense of purpose, such as attending his place of worship weekly or volunteering within his religious organization. Chris and I will identify coping skills for each of his warning signs. Lastly, Chris and I will construct a relapse prevention plan. This recovery strategy may involve seeking assistance from important individuals in the client's life, addressing issues related to their family of origin, and implementing daily self-assessments to monitor progress towards their objectives. An early intervention plan for relapse outlines the actions that the client should take upon the initial engagement and urges to halt engagement promptly. It is important that both Chris and his support system familiarize themselves with this relapse prevention plan to aid Chris in resuming his efforts towards abstinence. In this plan, we may include attendance at a 12-step meeting, such as Sexual Recovery Anonymous, to help aid Chris in relapse management, as well as providing social interactions. Next is my treatment plan for Chris. Chris has been experiencing intense sexual impulses for the last 3 years, increasing his pornography and internet chat room use, as well as an extramarital affair. Chris came to counseling for help in understanding these urges while also asking for advice on what behaviors he needs to change. The goal for this is, over the next 4-week period, Chris will develop skills to aid in coping with sexual urges. Intervention 1. Over the next 4-week period, the counselor and client will complete a comprehensive relapse prevention plan. Chris will identify warning signs, behaviors, and places that may be triggering, as well as learn new strategies and skills to combat triggers and warning signs. The counselor will provide psychoeducation on coping skills. This will be reevaluated at the 4-month mark. Intervention 2. Over the next 4-week period, Chris will increase his engagement in recovery-focused activities by attending his first Sex Addicts Anonymous meeting by the end of the month. This will be reevaluated at the 4-week mark. Problem area 2. Chris reports increased fighting and disconnection from his partner due to his increased sexual urges and increased in acting on these compulsions. However, Chris reports that he enjoys using pornography and chat rooms because they provide him with positive social interactions that improve his mood. He also reports feeling confusion, shame, depression, and conflict with his religious beliefs. The goal. Over the next 4-week period, Chris will increase communication skills and pro-social support. Over the next 4-week period, the counselor provides psychoeducation on the effective communication strategies such as validation, I statements, active listening, and emotional expression. Chris will role-play discussing several urges with his wife in session to prepare to have this conversation with his wife. This will also be reevaluated at the 4-week mark. Over the next 4-week period, Chris will increase his engagement in his religious organization by volunteering at his local place of worship once a month with his wife and children if possible, to increase social interactions. The counselor will teach Chris coping skills to combat depressive symptoms. This will be reevaluated at the 4-month mark. I feel that a 12-step group like SAA would be beneficial for Chris because it provides numerous advantages for those dealing with compulsive sexual behaviors. These benefits include a secure and encouraging atmosphere, accountability, a sense of community, and access to resources and knowledge through the 12-step program. SAA promotes camaraderie, alleviates feelings of isolation, and assists individuals in cultivating healthier coping strategies. Since Chris is turning to pornography and internet chat rooms for social support, attending meetings such as these could provide a safer and healthier outlet to decrease isolation. I feel that it is important for Chris to learn communication skills so that he is able to communicate his urges with his partner. 2 essential communication techniques are validation and the use of I statements. Validation entails recognizing and affirming another individual's emotions and experiences, thereby fostering a secure environment for them to delve into their feelings. Conversely, I statements enable clients to articulate their emotions and needs without attributing blame to others, which encourages comprehension and diminishes defensiveness. I would like to role-play these skills with Chris to aid him in feeling comfortable discussing these issues with his wife. Lastly, these are my reference slides. Thank you very much.